ما اسمي معنا. By the way, he's very يعني متواضع جدا. هو is very well known vascular surgeon بإيجيبت. يعني عمر أي واحد بإيجيبت ماشي زين على سوق الدجاج يقول لهم عمر فاروق بقول لك I know. وعندك طبعا الاونلاين is beautiful. هلا it's free ولا I don't know is online teaching.
It's
عندك
free.
YouTube. Yeah, I think most people they have to really register. There's a lot of education videos there. A
Yeah.
lot.
Yeah.
And tips and the tricks. So I think it's very important. حطينا لهم والله maybe we should put a link for on the group Omar, for the people to register on the online.
Yeah.
You know?
They are very much welcome. All free. And we have something like 5,000 in the vascular lecture.
Yeah, as I'm saying, it's very, very
Yeah.
resourceful.
Yeah.
All right, let's one start. I see Abdullah معي هنا, our fellow. Where's our fellows? And I only see only you are Abdullah. Abdullah, you are around, right?
Yes, Dr. I'm around.
Anyways, the other guys. So let me share my screen. How can I share my screen? Share screen, share. Here, share. All right. You can see it now?
Yes. Looks very obvious. Very nice.
Okay. Now what happened? I did. All right. You see my screen?
Yes, bro.
Oh, you see it. Okay.
Yes.
Let me just start recording for the other people, then we can start. Record. It's on the cloud. Okay.
Recording in progress.
Okay, good morning, everyone. We're going to start the first session to review on the cerebrovascular occlusive disease. Abdullah, you can start. Go ahead.
Yes, Assalamu alaikum. So this is a 55-year-old male brought to the emergency department by emergency medical services following the onset of left hemiplegia 4 hours prior. Symptoms have remained unchanged since their onset. CT without contrast showed no signs of intracranial hemorrhage, and CT angiography demonstrates occlusion of right distal cervical internal carotid artery. Which of the following is correct regarding the use of the antiplase tissue plasmid gene activator in acute stroke? A. Administration of weight-based heparin bolus of 100 units per kg and initiation of continuous IV heparin infusion should proceed antiplase administration. B. Close hemodynamic control.
Abdullah, we're not trying to answer the right question. Doesn't matter. The whole idea is to learn, you know?
Yes.
So let's start first when patient came, you know? The first thing they said, they did CAT scan without contrast, you know? Why
Yes.
don't do it with contrast? Why they said without contrast?
Why they said it is without contrast?
Yeah, why don't do it with contrast?
Without contrast, we can't see if there is ischemia or not.
No, you cannot see without contrast if there's an ischemia. Because when patient come, the only thing you want to be sure is hemorrhagical or embolic stroke, correct? Because
Yes.
the first thing when patient come with a stroke, you don't know is it hemorrhagical or ischemic stroke, you know. So the first thing you want to be sure is not hemorrhage. So the first thing you want to be sure is no hemorrhage. So the reason why you get CAT scan without contrast. No hemorrhage, then you are dealing with embolic stroke. It doesn't matter if you see a stroke on the CT or not, because stroke is a clinical diagnosis. It's not angiographic diagnosis at this level when you come early, unless you do an MRI, but it doesn't help. Why you should do an MRI for patient? We already came with the symptoms, okay? So when patient comes, the first thing you do CT scan without contrast, you want to rule out hemorrhage. No hemorrhage, then we know that we are dealing with embolic, stroke. Then that's what we do, okay? Then we start the treatment. but you don't even start heparin before CT. So when patient come, we don't start anything. The first thing you do is CT. So if we start on heparin, presuming is an ischemic stroke, then you find he has a hemorrhagic stroke, then you're in big trouble. Okay.
Yes.
So the first one, let's say first one, why don't give heparin? Pause.
Because
we want to know why this is wrong, this is so we can learn. And we don't just want to answer questions, So
transformation from ischemic to hemorrhagic.
This is not 100% correct because he's still less than 4 hours, right? So still fresh, But we don't give heparin because first, it's not going to change the outcome. Heparin will not dissolve the clot, correct? We know that, okay? And the second thing is this patient, he's within 4 hours, right? So he's within the period you can give a TBA, correct?
Yes.
When we plan to give a TBA, we don't give heparin with a TBA because it's increase of risk of bleeding. So anytime you're planning to give patient a TBA, you should not give heparin. If patient came like after 10 hours and you're planning like you just consultative management, then you may think give him, heparin. But if you're planning to possibly give him a TBA, don't start heparin. Even when we put patient when it comes with a lower limb ischemia, put him on TBA, like thrombolysis overnight, we don't give heparin. We just give heparin through the sheath just to keep it open. But we don't give systematic heparin because studies showed that giving heparin systematic with a TBA increased risk of bleeding, especially intracranial bleeding, Omar, you want to add something, Omar?
No, I totally agree with all what you said. This is very good educational point. The aim of the first CT is to exclude intracranial hemorrhage. In the CT angiogram, it's very important to know the level of the occlusion. And the 4 hour is very important in the question because the main thing here is brain salvage within the first 6 hours. And every bit of information here put you in a clinical direction. And this is very good for them, not just to answer the question, but to see every bit in the scenario, what it pushes you in direction. No, nothing to add from my side. It's fantastic.
Thank you. So let's go to the next one, Abdullah. So let's go next one.
B, close the hemodynamic control blood pressure to maintain systolic pressure less than 140. No, we want to increase the systolic blood pressure to maintain brain perfusion. So this is wrong.
But it has to be a reasonable increase, You don't put patient to 200, 210, then I mean, to be like these are 160, 180, 170, it's like something. Usually I do it when we do a surgery during our carotid surgery. When we clamp, always we increase the pressure around 160, something like that, So you want to be in high pressure, but not very high. So this is wrong. Correct. Next one.
C, intravenous administration of alteplase is contraindicated in the time elapsed since the onset of the event is greater than 3 hours. What I know, it's up to 4 hours. Then from 4.5 to 6 hours, it is catheter directed alteplase. So I think this is wrong. It's up to 4 hours. We can administer IV.
This is correct. Even though now when I talk to the neurologists, they said even up to 24 hours, sometimes they try to do TBA. Maybe I get some feedback from the other consultant. But I think it's a good idea. It's more than 4 hours check with the neurologist because sometimes they have some update. But for the exam, I think 4 hours is, or 4.5 or 4 to 6 hours is maximum you can go with. Okay, what's about D?
Alteplase may be administered prior to catheter-based thrombus retrieval. Yes, I think. E, alteplase is contraindicated in patients presented with severe stroke. I think D is the answer.
Yeah, I mean, first, yes, you can give it before, and by the time you get him to the catheter, you can give him the ER. You can give him an IV alteplase until you get him to the, to the cath lab, and then you do catheter-based thrombus retrieval, because sometimes it's not a clot, it's a atheroma. The reason why sometimes you need to use a, retrieval, to retrieve the plaque. It's not contraindicated in severe stroke, no. Unless if you do a CT scan and find hemorrhage is different. But if it's just severe stroke without, intracranial bleeding, I don't think it's a contraindication, All right, so let's hear. I saw Dr. Muhammad Mana من أمريكا, شمس سيارته. Muhammad, you are with us? I think maybe I saw him around. Anyway, anybody want to add anything or any question before we go to next question? All right.
Quick remark. There was a guideline in the ESVS in 2023 regarding carotid atherosclerotic disease. And this came very quickly after the Society of Vascular Surgery SVS carotid guideline, which came 2021, just after 2 years of them. And one of the main changes was in the thrombolytic therapy post-acute stroke. If you read the guideline, the first page, they mention we are different from the previous guideline in this element. And this is the importance of this question, because these questions depend on carotid guideline ESVS 2023. And they mention clearly that catheter-based thrombus retrieval is now having grade 1 recommendation in recent stroke in experienced center. Secondly, the thrombolytic therapy, which was widely used in the SVS guideline of United States, now in ESVS it is restricted due to, I think, a 12 randomized study which showed exactly what you said, Samuel. There is more evidence of bleeding complication with the thrombolytic therapy. And this is the importance of this question. Unless you know the most recent ESVS guideline, you probably would not have answered the correct answer as it has been done.
Thank you, Muhammad. Muhammad Rafat, I saw you driving your car. Are you listening to us? We can't hear you. You are muted.
Yes. Yes. No. Yes, I'm listening. Sorry.
Yeah. Do you want to think about this acute stroke and TBA? Any new recommendation?
Sure. So there have been a lot of changes. Let me stop here. There have been a lot of changes in recent years in management of stroke. And, in the U.S. at least now, they have stroke centers where you have specialized centers, like Dr. Omar said, where you handle strokes. So the patient comes in, page goes out to multiple people and x-rays. So the x-rays that they get done initially, the non-contrast CT scan, as you mentioned nicely earlier, and also you get a CT perfusion studies where it's basically see a penumbra or ischemic mismatch somewhere, and that gets done pretty much routinely on everybody. And then to determine what TPA versus not TPA. I haven't seen IV TPA for probably 3-4 years. Given like Dr. Omar said, most people know they're doing catheter-based treatment, whether PA or suction from. So the point I'm trying to make, it's stroke management now. It's a multidisciplinary team. It's time-based. It has to be done on a very quick and in a timely fashion, and it has to be neurologist, neurointerventional radiologist, and if the extra cervical carotid or extracranial carotid arteries involved, vascular surgeons also involved in this patient. So I think that's this is what the current treatment for stroke right now, and there's a pretty good outcome when they help these people. They help these people pretty good if they can.
Yeah, I agree with you, Muhammad. And even at King Faisal, we have the stroke team, as you said, exactly what you said. We have like a code. The moment the patient walks to the to the ER, we have a code, stroke code. Then they activate everyone, the cath labs, and they do, as they see, CT perfusion. It's very important to see how much damage so they can see which areas they need to reperfuse it. And then they go with a catheter-based thrombus retrieval, as you said. So this has become very important in high, volume center. Yeah. And the outcome is great, really. All right, let's go to next one now. Who's with us from the fellow? Or any volunteer? Let me see what our fellows. عبد الله كأنك أنت الوحيد موجود.
أهلين دكتور.
هلا دكتور سامر.
مين معي؟
يحيى.
يحيى أنت هنا يلا يحيى.
بسم الله. 55 years old female present with exercise induced right arm fatigue associated with dizziness. Systolic blood pressure is 80 on the right and 135 on the left. Representative image from cerebrovascular duplex scan are shown below. CT angiography showed orifice right subclavian artery occlusion. Which of the following is correct regarding the subclavian artery revascularization? In the duplex study showed.
Before we go there, let's see what you see in this study. This is the left and this is the right. Can you just comment on this one, Yahya? This one.
Yeah, one.
This is a lot subclavian, correct? You see nice biphasic
Triphasic wave.
And you see the vertebral artery. This is usually the normal vertebral artery, you know. You don't see like triphasic, you know. Just see like that, monophasic. This is the left. You go to the right, you see the same. You see like now monophasic here, subclavian.
Yeah.
And you see here the vertebral artery. What do you see in the vertebral artery?
Retrograde flow.
Retrograde flow, okay? So
yes.
with all this history, so what does that mean? What this patient has?
Occlusion in the
subclavian.
Yeah, occlusion in the subclavian and the flow in the vertebral retrograde through left side.
Correct. The most important to remember that you say when you do looks at any duplex ultrasound, when they look at the vertebral artery, always they put next to you picture here, like put it here, the common carotid artery. They always put vertebra and common carotid artery. You know why they put two pictures next to each other? To see the reverse flow.
To compare flow, antegrade or retrograde, reverse
so
flow.
It depends on the color, because the color usually is the technician decide on the color. So he may decide the arterial to go blue, you know. So you have to see what the common carotid is. The common carotid blue and this one is blue. Even they are blue, this is antegrade. Okay. And even this one could confuse you because it depends how the technician assign the probe to the waveforms. So always when you look at the vertebra, you don't depend on the way how it looks, reverse or the color. You have to see the common carotid. The common is red and this is blue, then it's a reverse, or the vice versa. If the common is blue and this one red, then the reverse. Same color, we are antegrade. So always at the end, if you look at ultrasound, always you look to picture here when they come to vertebra to be sure it's antegrade or retrograde. Okay, just a small note. All right, let's say so. This guy has subclavian artery occlusion and Steele syndrome, so he needs a surgery. Correct?
Okay.
What type of treatment we have? We have, you know, what kind of treatment for subclavian artery occlusion, which is symptomatic? What options of treatment we have?
Either open or endovascular.
Correct. And open, we have either bypass,
carotid subclavian or transposition.
Do you know what's the difference between both of them? Well, it's with a bypass. Do you use a vein or we use a graft?
Graft.
Why don't you use a vein? Because they kink. Okay? So the kink, because keep moving. So this is the only place where the vein, they don't work as good as the graft. See, there's a couple of places where bypass graft is better than the vein. You know what the areas? This is one of them. The neck, always when you do calcium, so you don't want to sacrifice even this artery. So really these days, carotid subclavian transposition is very rare. Because they found that the patency is not better and you have more complications. Surgery become more difficult. Why should do it, you know? I maybe did once in my career. I can ask now Muhammad and Omar their experience, but I just go right away to the bypass if I have to do surgery. Omar, شو رأيك عمر؟
Yeah, I totally agree with your approach. I probably have done more endovascular intervention to these cases rather than open. The beauty about the reverse flow and vertebral artery that you're not worried about embolization because you already got natural protection by the reverse flow. Um, so, but it's not easy. The endovascular approach. Open is more controlled, but still it's a bit invasive. I totally agree. No one use vein in that area, as you mentioned. Reinforced graft is a standard technique.
And when you do endovascular, Omar, do you go transfemoral or transbrachial?
I always do them transfemoral and transbrachial double approach. You always need to have the reverse transbrachial, 6 French sheaths, and the 7 to 8 French sheaths from transfemoral. Many occlusion are easier to pass from the transbrachial approach, but it is more easier to deploy the stent from the transfemoral approach, and we use multiple tricks to protrude into the aorta just 1 or 2 millimeter into the aorta, which is not easy. I usually put a guide wire and extend it to know the limit of the aorta during stent deployment. But you need, as a standard double approach, you cannot do it from a single approach, neither transbrachial or transfemoral safely. And I think this is more or less a common approach how to do them.
Okay, thank you, Omar. I agree with that. At first, you have to differentiate between stenosis or occlusion.
Yeah.
If you're dealing with a stenosis, then you can go either transfemoral or transbrachial, which one is easier. So stenosis is not difficult. You can get cross and put a stent.
Yeah.
The difficulty when you have a complete occlusions.
Yeah.
The problem, even it's easier from transbrachial to push there, but the problem is that when you have occlusion, you're going blindly. And if you push from the brachial up to the aortic arch, you can cause a dissection. It's the same like when you do an iliac occlusion. If you go from below, you have to be very careful when you're pushing blindly because you end with a subintima and the aorta and aortic dissection. And the same here. And especially arch is very, very dangerous because it's very high volume. The reason why when I have a complete flush occlusion, I prefer to go from femoral. So at least when I'm pushing hard to get through the occlusion, if something happens, at least we'll go toward the subclavian, not toward the arch. This is the only thing you have to keep it back in your mind, you know. But most of the time you have to try both, as Omar said, to go from both sides, you know. But the only thing when you push from the brachial, just be careful, be gentle, and know your limit. When you deploy, as again, like the same aortic bifurcation, the stent has to be protruded inside the aorta because the disease is really coming from the aorta, not from subclavian. So you cannot put like a flush stent with the subclavian. It has to be protruding inside the aorta, the aortic arch. So this is very important, you know. Covering or uncovered stent, I don't think make a major difference. But if you decide to use a covered stent, you have to be very careful with the sizing because you don't want to cover, you know, vertebral artery. So if you are very close from vertebral artery, I prefer to use uncover in case the stent covers subclavian, the vertebral artery be uncovered stent, you know. This is for endovascular. Muhammad Rafat Shuraya, give us some.
Yeah, so I agree with the endovascular first. My approach to this, I do endovascular even for occlusion. So if it's stenosis, I usually go transbrachial if it's easier. And like you said, you can cross it easy and you stent. If it's occlusion, I always get an aorogram and simultaneous dual axis, and then you see where you point A and point B. And then there's about maybe 70% chances to cross this endovascularly if it's occlusion, if you do it from below or from above. But you have to have point in, two ends. In terms of the stent, I always use cover stent for these. There's some at least data that shows that cover stent has more patency, and I always use balloon expandable stents for these. So the balloon expandable has been shown. This is one of the areas in the body that you better to use balloon expandable stents. Like you said, you have to watch for lima, you have to watch for vertebral. And in terms of the protrusion into the aorta, you protrude about, some people even protrude up to half centimeter, which may be a little bit too much. And that's how much we protrude when we do fenestrated grafts and things like that. And then you have to flare it also. So if the stent's about 8 millimeter balloon or 9 millimeter balloon, you get a bigger balloon and you flare it in the aorta. You have to be very careful. So endovascular treatment is the first line of treatment, whether it's occlusion or stenosis in my practice. In terms of carotid subclavian bypass, I totally agree with you. Transposition is a procedure that's not commonly done now. It's very difficult. Sometimes you don't have enough length to reach, and you have to dissect in a dangerous area. So graft is usually used PTFE, 6 or 7 millimeter PTFE graft. It's straightforward. It's a much safer operation, like you said, so in terms of this issue. So I agree with you in terms of.
Okay, so let's go through the question now, Yahya. Sorry, let's go.
I just have a small comment regarding this question. If this question was in the European board, the candidate should say, I need to see the angiogram before having any decision regarding treatment. Because here he got a scenario and he got a duplex image. To me, this is insufficient information to decide which bypass, which end, because subclavian artery occlusion can be just 1 centimeter and can be 5 centimeters. So management is totally different. Secondly, I have seen many cases which have lima, left internal mammary artery, coming from the very near to the occluded segment, causing revascularization to left main. So these cases, if a patient has previous lima or cappage or open heart, which is not unusual in this atherosclerotic patient, you need to multidisciplinary with a cardiothoracic and the cardiologist as well. There is a lot of tips and tricks to do it if lima is very nearby, and sometimes you abandon the whole procedure if the lima is very, very near to the occlusion and if it is vital to the coronary of this patient. If it was me, I would say I need to look at the angiogram before any decision-making process. But here he did put the option of management just after duplex, which I think is not sufficient information.
100%.
Right. Yeah, but let me ask a question. We have a scenario where we have two patients really referred to us with a chest pain because he has a lemma, which is patent, and he has subclavian artery occlusions, The question here is, should we try taking a chance, with to do endovascular, or just safer do carotid subclavian bypass and done with it? Because here, if something went wrong, is the heart also on the stake, because you may get MI on the table if you close the or get dissection or you close the subclavian, especially you're dealing with occlusion, not stenosis, So what do you think? What approach you will go? You try endovascular, you just go right away to surgery?
I've done one recently, just with the stenosis wasn't occlusion, we did an endovascular. So, but you have to be ready to do open also. So you do it in the hybrid room and be ready to do it open. And again, depends, like Dr. Omar said, depends on the distance where the lima comes off in relationship to the stenosis. But I think the potential for carotid subclavian bypass operation, pretty morbid can be, sometimes if you have a complication. I mean, it's not usually you don't, hopefully, but it's worth trying to do endovascular treatment if it's feasible, and I think. I've done at least 2 cases in my career with lima stenosis. I never really had occlusion yet. So, but recently I've done one with the stenosis and it was going fine. But we were ready to do open. So we had the team to open if we need to. So
I think for the junior fellow, junior consultant, and the fellow, I think it's safer in this situation. Just do carotid subclavian bypass. Don't take a chance.
Right.
Just do carotid subclavian bypass, be on the safe side, especially if you don't have much experience. Or if you do endovascular, I told them, if you want me to do endovascular, I can do it, but I'll do it in the cath lab. If something happened, at least we'll be next to the cardiologist, they can salvage the lemma or something like that. But to be on safe side, I think this case is better just do carotid subclavian bypass and get out of it, All right, so let's go to the question now. هو يحيى. Yeah, let's go يحيى.
Okay, Dr. Samer. Answer A, carotid subclavian bypass has a lower risk, a lower stroke rate than subclavian carotid transposition.
If he's correct or wrong or correct, what do you think?
Wrong. I think it's in the opposite side. Transposition more.
No, not really, Yahya. Study showed it's no different at all between stroke rate, patency, mortality, morbidity, all the same. The reason why it's mainly is a physician preference, but all the study shows it's no different in any of them. You know? So this is the reason why this one is wrong. Okay. Well, let's go
Okay.
next one.
Carotid subclavian bypass has higher patency rate than subclavian carotid transposition.
This is wrong. I said the same patency.
Same.
Yeah.
Same.
Same patency, same stroke rates, same mortalities, all the same. So it's no different between. Otherwise, we'll use one of them. If we think patency is better, most people will use transposition. But all the studies show there's no difference. Okay.
Okay, Dr. Samer. Subclavian artery stent placement is contraindication due to risk vertebral embolization.
Not really.
Not contraindication.
It's not contraindication. I mean,
Yeah.
and now I said it's difficult to answer this one because you don't see images, as Dr. Omar said. But in general, if you talk in general, it's not contraindication. All we do is now even is the first line of treatment now called stenting. Okay.
Okay.
The risk of
The most-
is very low, especially if you have like this case because as Ahmed Rafat said, you have a retrograde flow, so you have a reversive flow. So you're already protected. So you're not going to get vertebral embolization, especially in this situation. You know, so it's very safe. Yeah. Okay.
The most common complication of bypass or transposition is Hernia syndrome.
It's not really. I mean, Horner syndrome.
No.
Yeah, go ahead.
A, carotid subclavian bypass has improved patency when performed with synthetic graft compared to autogenous vein.
So what do you think?
As you said, Dr. Samer, it's same, but I will go with A, synthetic graft.
Mhm.
Yeah, synthetic graft compared to autogenous vein, more patency.
So his answer is E. As I said, this is
Yes.
the area where the patency is better than vein, not because the graft, because the kink. You know, so any area you have a kink, usually graft work much better than the vein. Okay. So to be the right answer. The most common complication of bypass or transposition is Horner. No, Horner only see it in transposition. We don't see it in bypass. So this is wrong. Okay.
Okay.
Let's keep going. We're running late. Let's go to the next question. Who is with us here also? أسامة معنا شيء أسامة موجود أحمدي
ايه موجود دكتور تفضل.
أسامة let's take this question number 3.
Okay. 57-year-old man with medical history of hypertension is referred to management of asymptomatic 3.6 centimeter fusiform left internal carotid artery aneurysm. He's a chronic smoker and has no history of neck trauma. CT angiography demonstrates a significant volume of intramural thrombus in the aneurysm sac with approximately 60% stenosis of the internal carotid artery flow channel.
مساء النور
He
يا
has
فندم،
no
معلش
history of
استاذنك انا في مؤتمر
amyloidosis
مع
or
دكاتره في
other
امريكا
transit ischemic
عشان
attacks.
بنوضب الحاله، استاذنك
Stroke
تكلمني كمان نص
symptoms.
ساعه.
The indication for surgical
شكرا
repair
حبيبي،
in this
كتر
case
خيرك،
is
شكرا، مع سلامتك.
Before we start, so we're dealing with asymptomatic internal carotid artery aneurysms, correct?
yes, yes.
Now let's talk about a bit asymptomatic. What's the treatment of internal carotid artery aneurysm?
Internal carotid artery aneurysm.
What's the treatment?
The treatment either stenting or open repair filter.
Correct. And why we need to treat it? What's the risk of the internal carotid artery aneurysm? Is the
Internal
risk
carotid artery aneurysm cause of embolizing stroke also. Has a high risk of stroke, yes.
rupture?
Also very susceptible to rupture in case of huge aneurysm. Any trauma can cause rupture.
But do we treat them because of afraid of rupture of embolization?
Non-embolization.
What other artery has similar like aneurysm characteristic? which you treated for embolization, not because of rupture, you know?
Embolization with
Aneurysm in your
small
body.
renal arteries.
No, renal artery may rupture. No, renal artery really treated for rupture. Which artery you treated for embolization, not for rupture? Popliteal, right?
Yes.
Remember? So popliteal artery, same things. This is two area where we treated not, we are not worried about rupture, we are worried about embolizations, you know. So internal iliac and popliteal artery, I think we treat them because of embolization, to prevent embolization, okay? What the size depend on? Do we have a size here or no?
Yes, 3.6.
I know what I'm saying. When we treat them, do we depend on special size to treat them? Like more than 2, more than 3, more than 4?
Yes, yes. I can't recall the number, but I think in carotid, more than 2.5, I think.
Okay. In the cut view, they go with the size of the artery, you know?
Yes.
Correct?
Yes, yes.
Right, you can do some comment, Muhammad. Well, how you
So
wanna
I haven't really, this is a rare condition. I've treated maybe a few in my careers. I do a lot of carotids, you know, I do about 70 a year plus, but this is a very complicated condition. You know, you treat, like you said, if it's twice as much or 2.5 times as much as the native artery, then that's an indication for treatment. If you have thrombus, mural thrombus, that's an indication for treatment, irrespective of the size. Technically speaking, these are technically can be very challenging. Sometimes you have to have, if it's very high, you have to have ENT available. I usually nasally intubate these patients, and you try, you have to study them with scan before that, it's accessible. Then the key to during the dissection to not manipulate too much of the carotid artery. Heparinize immediately as soon as I get down to the artery. Heparinize, and you want to basically go to the healthy area and clamp before you do anything else, and then the rest depends. You can do it. We've done aneurysmorrhaphy, and or you can do a vein graft, and I've seen even my training people, they put a synthetic graft for this. But the key is you have to plan this very, very carefully. If it's too high and you need ENT to be available to do subluxation or things like that, you have to be ready for that. So.
Okay, my question to you, Muhammad, is that whether endovascular, do you do an endovascular for these cases?
I have. Technically, you can. I've seen it done. There was a cardiologist I know. He did one, with Viabon. I'm worried about, just manipulating the thrombus and things like that. So he was able to put a filter and did it. Endovascular is people do it. There are people doing that. So, and it's hard to say which one safer. So.
Yeah, I think I agree with you 100%. So the idea, guys, in the internal iliac artery aneurysm, I think surgery is still the gold standard treatment. I think the problem with a Viabon, I think it's too much. It's a big within the internal carotid. That's why we don't use it. We don't use them in the internal carotid artery stenosis. Because if you think about it, you should put cover stents so you don't get embolization, but we don't do that. It's too much, so it's high risk of thrombosis. So I will not do it unless it's like an extreme situation, maybe radiation neck, something like that, old guy, whatever. But I think if surgery carry patients good risk, I think surgery is the standards. You just go there, take it out, and put a vein. Again, sometimes people say put a graft. Yes, I agree if they don't have a vein, but I think also vein should be your first option here, because no kink like in the case of cave and bypass is straightforward. So I think the most important also to do an occlusion test before surgery, because you like it for some reason. If you go there, if it's too high, very fragile, so it's very important before surgery to do an occlusion test. And when you do occlusion test, guys, has to be for 30 minutes. You can't do it for 10, 15 minutes. It has to be for 30 minutes to get a real occlusion test, So I think it's very important before that. I think that's mainly.
For the past probably 5 years or so, I routinely get a CTA hit on every carotid I do, so just you have an idea what's going on, because sometimes, I know you spoke about shunts the other day, and sometimes you have to at least two or three times in my career that you had to go in and ligate the carotid. So it'd be nice to have that piece of information, whether everything is open or not. Right. So it's right now it's routinely for my before I do carotid surgery. And I think stent can work now if you use TCAR. TCAR now we have a reverse the flow. You shut down the flow completely to the brain and you reverse it. But like you said, Vivan, the product is too big for this, and the mismatch between the common carotid and internal carotid is too much. So to do stent these patients.
Yeah, I agree. Omar, I didn't hear your voice, Omar. I'm sure you have a lot to talk.
Yes, it's number one, it is rare cases that we see. Number two, there is no, let us say, big series of number crossing the number of 50 or 60 of these cases. So we don't know exactly what is the natural history of these cases. Number three, the main target is to prevent embolization. 60% can be very easily managed to conservative. Fourthly, I know the skills of Viaban under protection device and putting it, but I think because I know the endovascular little bit, I know the open little bit, I will be much happier on the open approach. Once you get control of the internal carotid artery, it become like aneurysm anywhere in the body. But the problem with endovascular, even with Viaban, just a little movement of the wire, putting some of the thrombus into the brain, a stroke is not something easy to play with at all. And usually in this area, if it has been seen by cardiologists, they prefer endovascular option, especially with the new development of micro mesh carotid stent, tapered. It can act like a covered stent, even if it goes to external carotid artery, shouldn't have a problem. But we don't have a big series. It depends upon your skills or past experience. And if I was the patient, I will go to Samer and tell him do my carotid.
Let's go to that question. Let's
Or
go
Dr. Muhammad Rafat in USA if I have the visa.
the first. Go ahead, Osama, with the first.
Okay. Risk of rupture of carotid artery aneurysm more than or equal 3 centimeters in diameter. I don't think it's the right answer.
Now was the indication for surgical repair because of the risk of rupture.
No, in this case, the indication of repair is the thrombus more than risk of rupture. B, lack of efficacy of anticoagulation therapy in preventing unilateral stroke. Also, this is wrong.
Yeah, why is wrong? Let's go one by one. Why is wrong?
Yes.
We don't have any study really look at that to tell us that anticoagulation alone is enough. So the reason why
in this case already in this case in the CTA that they show there's intramural thrombus already. So I don't think the anticoagulant will be enough to treat this patient.
Okay.
So C, risk of Horner syndrome with a large internal carotid artery aneurysm. Could be there is a risk, but not the indication for repair in this is the case.
And usually we don't see Horner syndrome with this
Yes.
large cranial nerve, Horner is more sympathetic nerve, So the
Yes.
aneurysm large, they compress more on the cranial nerve than the Horner, sympathetic. So
Yes.
no risk.
Yes. D, risk of hemispheric stroke due to intramural thrombus. I think this is the right answer. We'll see the last one. E, presence of internal carotid artery stenosis of 60% meets requirements for repair. This is a wrong statement. So I think the answer will be D.
It's wrong. Where's the last one is wrong? Because
The
we
presence of
know
internal carotid, yes, 60% it is, yes.
so this
The
is an
60% it is not indication 60%.
well, let's say 70%.
70% asymptomatic patient.
No, I'm saying the indication for surgery because this causing 70% of
Yes. No, 70% stenosis in asymptomatic patient. Yes, it's considered yes.
Well, let's
in-
say for you. Let's say presence of internal carotid artery is only 20%. And this patient, same patient, but only has 20% internal carotid stenosis. Are you going to tell him, no, you don't need the surgery because stenosis is only 20%?
no, the first thing I was asked is symptomatic or asymptomatic.
Like this one, 3.6 centimeter aneurysm is asymptomatic. And this aneurysm causing only 20% stenosis.
Either way, I will take it based to because the risk of embolization also is high in the aneurysm.
Okay, it's correct. So stenosis doesn't matter. If it's 20, 50, 90, it doesn't matter. We're not doing for stenosis, we do it for embolization, you see? So it doesn't matter what number they put here, it's wrong. See, even they put 10%, doesn't matter. We're not doing for stenosis, we do it for embolization, correct? So
Yes.
it full wins the exam. Whatever they put the number here doesn't matter. We do it for embolization, okay?
Okay.
Well, let's go next one so we can go a bit faster. Who's still here? Who else here? Abdullah, I'm going to have to go back to you, Abdullah.
Okay. The lesion depicted in the figure, a white arrow, can be associated with the germline mutation in the succinate dehydrogenase complex subunit D gene. A genetic testing should be performed preoperatively with concurrent familial screen in the presence of
What do you see first in the picture?
carotid body tumor.
So, and when we do a gene study, when we do genetic study in the carotid tumor, when we think it is right?
طبعا إذا كان ال 24 hour urine metanephrine is high.
Now this tell you is more is inactive or not. But usually
Yeah.
when we do genetics, when patient you think I should send in for genetics?
One of يعني suggest it is familial, possibly bilateral tumor.
Correct. Has bilateral tumor. He has a familiar history of carotid body, like his brother, sister has carotid body. Then you start thinking about genetic, correct? Or
Yeah.
if he in bilaterals, correct? Or if he's young people also, you have to think about it. And the last thing the last one, if he has extra, like, somewhere else, or
Okay.
if you have it somewhere else in his body, then you have to think about genetics, okay? And this is genetic. You have to remember this is the only gene you see in the carotid tumor familiar. I know it's a very long name for this gene. Anyway, so let's go to the question. So what's the first question? So they're asking when you're going to order the screening for the family. So go through one of each one and tell me it's correct or right or wrong.
Champlain 3 tumor, no. It could be an sporadic or familial. Age older than 50 years, no. Unilateral involvement, no. Bilateral. Positive MIBG scan, no. It can be in both. Metachronous paraganglioma, yes. If it's present in the chest or abdomen.
It's an easy question, very straightforward, but you have to know about it, So let's not spend our time here. Let's go to question next one. So we got a bit fast. Next question. Here, I want to take the here.
Okay, Dr. Samer. In the CREST trial, the reported perioperative myocardial infarction after carotid endarterectomy or carotid artery stent associated with?
All right. First thing, my advice, guys, when you go to the exam, you have to read CREST trial. It's very important. CREST trial is very, very important trials. This they compared transfemoral stenting versus surgery. This is there's a lot of trials, but this is one of the largest trials, you know what the trial compares TCAR with the surgery? What the name you have to know about the other one? Called Roadster.
Yeah, Roadster 1 and 2.
Correct. So this compared TCAR with surgery, but the one compared to transfemoral with surgery is a crest. The main one is crest. So guys, you have to read about this trial because always you get a lot of questions in the exam. Okay. So are you familiar with the crest trial? So we can go through it, or let me summarize it first. Abdullah. Well, let's summarize the crest trials. Crest trials, they found that if you look at the stroke rate alone, no question, transfemoral, they have higher chance of stroke, minor and major, than surgery. If you look at the MI, but MI defined as increased troponin with EKG changes or symptoms. You notice the MI is higher with the surgery than stent. But if you put them all together, stroke, MI, and death, they found no difference. Okay, this is something you have to know about this trial, or the most important thing about trial. Okay, so let's go through them, and then we'll hear from the other guys. So let's go through the first question.
A. Increased perioperative mortality for CAA, but not carotid artery stent.
Be careful, because they didn't show, because this is a cardiology, they want to do stenting. So they were looking not for more perioperative mortality, they were looking for only EKG changes and troponin level. So even some people, they were asymptomatic and they considered as an MI, you know. So really did not show this mortality is higher, but showed is the MI, the troponin and EKG change is higher. But some of them are asymptomatics. So I don't know how important is that, but there was a showed. So you have to be very careful. So perioperative mortality was not higher, but MI was higher. Okay.
Okay.
Next one.
B. Increased risk of perioperative stroke for CAA, but not CAS.
Was opposite, correct?
Yes.
CAS was higher perioperative, not the CA. Okay, let's go to 3.
Higher composite risk of MI, stroke, or death for CAA.
So all the same. This is the final, all the same. So hey, for this reason, they said, okay, let's go start doing stenting, because now they found that MI, stroke, and this are the same. All right?
Yes.
So,
An equivalent impact on quality of life compared to stroke and long-term follow-up.
let's go to this one. So what happened is that when people, so now you have two kinds of treatment. One, you have a higher chance of MI, one you have higher chance of stroke. If you do a stent, you have higher chance of stroke. But if you do a surgery, you have higher chance of MI, even though the total is the same. They said, okay, let us look at the quality of life. They found the people who has an MI, they have a better quality of life than a stroke, because stroke, you end with a bedridden, you know, on the chair, whereas MI, it's just like an EKG changes. It's not a big deal. But they found that is that if you do a surgery, yes, you may have higher MI, but really quality of life is better than if you do stent and end with a stroke, and quality of life is lower. So this is the only thing they found different. So if you have a choice between having MI or stroke, I think I will take MI than stroke. Especially this could be an asymptomatic MI, you know. So the D is an equivalent impact on quality of life? No. They found the quality of life is worse after CAS than CA because higher chance of MI than surgery. Let's say now the last one.
The last one, less impact on quality of life than stroke and long-term follow-up.
And about the CAS, no, this is wrong. So let's say what's the less impact on about CAS associated with less impact on quality of life? No, than stroke. It's worse. So the D is as equivalent impact on quality of life comparing with stroke, equivalent impact on quality, impact on the quality of life compared to stroke in long-term follow-up. This is wrong. It's wrong. Risk of operative stroke. So which one is the right? Let's go one by one again. Increased rate of mortality, this is for sure is wrong. Okay. Increased risk of operative stroke for CA. No, this is wrong also. Higher composite is wrong. Less impact on quality. No, I think E is the right answer. Yeah, less impact on quality of life than stroke in long-term follow-up. Increased operative mortality after cardiac or cardiac stenting associated with less impact on quality of life. Less impact on quality of life than stroke in long-term follow-up. Not answering, I don't understand the question. But what I know is that if you have a stent, you end with an MR, with a stroke, you have a bad quality of life than if you have a surgery. So you have better quality of surgery after CA. Omar, what do you think, Omar?
Yes, I
Something
totally
I'm
agree
missing
with your feeling. The CREST trial is very important trial, affected a lot of our practice, and one of the it showed the advantage of carotid endarterectomy, and the rest for artist stenting. I think is very important for the exam, and I agree totally with your point of view, all what you mentioned.
But I think even the E is wrong. Should be more impact on quality of life is stroke than stroke, because MI have less impact. صح
Yes,
صح الستنت الام.
yes, I agree.
Anyway, so this are guys what you have to learn, that MI has less impact on your life quality than stroke. Okay, this is the end of it. Omar, Muhammad, you want to add something before we move to the next question? Busy maybe. Well,
Sam, hello.
go ahead. I hear you.
Yeah. So carotid stenting, like you said, it can cause more strokes versus surgery. They say it causes more MI. That's what really CREST is about. And CREST is CREST 1 and CREST 2. So that's the fellows need to know this for exam. With TCAR now, they say in TCAR basically has the same rates of MI, or less MI actually, but the same rates of stroke with surgery. So this dynamic, there are studies now being done, but it's really transfemoral stenting now is almost obsolete. I have not done one probably in 5 years. Yeah, it's rarely done. So it's really the open now with TCAR. TCAR is coming on very hard now, and half the carotids now are being done, maybe not half, maybe close to half are being done TCAR now. It's very easy procedure to do so.
I agree with you now. TCAR becomes standard transfemoral. It's very too much headaches and high chance of stroke across the arch. But unfortunately, it's a small company. We put them to Saudi. They said they cannot provide us with the instrument because they are a small company and they have a lot of requests from.
Right. From my personal experience with TCAR, I've done probably close to maybe 200, close to 200 or 200, something like that. It's a good procedure, but there's downside. It's very tempting to do everyone TCAR, but with calcification and things like that. So it has to be refined. There's no trial to compare the three, but they're doing that now. So, but the carotid stenting transfemoral it's gone. Medicare now, or the payer in the US allow to do carotid stenting for asymptomatic even. You have 70% stenosis, which is dangerous, I think, in the wrong hands. So.
All right, let's go to move back to you. Let's go to number 6. Is Ahmed معنا ممكن? Is there? Ahmed? Maybe he's busy. All right, Samer. Samer.
Yes, Mr. Samer.
Let's go to this question.
Okay. Immediately after stent deployment during transfemoral carotid artery stenting, a patient develops altered level of consciousness and hemiparesis on the contralateral side. Angiography revealed acute thrombus of the internal carotid artery to the level of the filter. The next appropriate step in management would be.
Okay, before we go through this one, this is not a common, but it could happen. I'm sure Muhammad Rafat, who if you do enough carotid stenting, you're going to see it. So what you do. First, what the pathology? The first thing you have to think, a couple of things. First thing you have to think about filter is full of thrombus or atheroma. This is the first thing we think about. Second thing could be dissections, which is common. It's not common, but could happen. The third thing you think about thrombosis. So I have to put them. The teaching which I have when we start doing this stenting is that if this happens, the first thing you remove a filter and then it'll be the angiogram. But this
Right.
also hurts us because you may lose your access, especially if you use dissections. The reason why here we use ambush shear, which is you can remove the filter and keep the wire. But some filter you cannot. You have to remove the wire with the filter. And I think this is very dangerous because if you lose your wire and you have a dissection, you're in big trouble. So you have to be very careful and see what you are dealing with it.
I definitely agree with that. You have to remove the filter and study, but
In cases like that, how did you approach it?
and then you have to see also. I don't know about I always shoot the brain before I get a full picture of the brain circulation before and after I start. And if there's any embolization distally and or dissection, this dissection is stenting, but if there's any problem there, probably have to get neuro IR involved in the case.
I'm saying here is a scenario, Muhammad, that you did angiogram, your filter is still there, you see float the filter and stop. So you don't know what this, you don't know because it's stop.
Yeah, you have to remove the filter and shoot, like you said. That's first, and then you have to look for dissection probably.
Correct. But to be sure that the wire is still there, because if you lose the wire,
Yeah.
you can very important. Dissection, understand you fix it.
That's
here-
why, like you said, the NAV6 or ambu shield filter is crucial for. I don't know anybody use spider filter for carotid anymore. Now.
Correct. The problem here, they didn't put this answer. They want us to give a TBA index, really, which I think is also reasonable. But this is what, when I read these questions, I know they don't mention about removing the filter. They want us to just go and give TBA.
Yeah, this is, to be honest, this is poorly written question, because you don't give TPA as a vascular surgeon for carotid. So if you have a carotid problem, or a problem, you have to get the neuroradiology involved in the case. So you can't just give TPA to. You can't give just TPA to carotid. Yes.
I agree. I mean, some of the question is not really good, but again, the whole idea is not to solve the question, to learn from them, So even though, so let's go through one by one and see what the options.
Okay. Yes. A, immediate conversion to open carotid endarterectomy.
What do you think? Is it a good idea? Just go and open?
No, I didn't think so. It's the good option
Why not?
because it may cause more damage to the artery. I think.
Like anything in surgery, you have femoral artery thrombosis, you open, do thrombectomy, and you're done. Why not go and do it to open? Then, for two reasons. First, you're doing cardiac stenting, right? So that means this patient is for surgery to could start with. This is what you're supposed to understand, right? Because otherwise, you should for patient could risk for surgery, at least until now. Okay, the second thing, you already have a brain ischemia, right? And most of these cases done under local. So now imagine you're going to convert to open. How much first you have to intubate the patient? You have to prepare for, you have to position the patient. You're talking about at least 15, 20 minutes, right? By this time, brain is gone. So this is only, even though it sounds very nice solution, but it's not good in this scenario for these two reasons. First, it takes too long, so you increase your brain
Ischemic time.
And second thing, most of the patients high risk for surgery to start with, so it's not good for option. Okay.
Okay. So B, emergent transport to the CT scanner for evaluation of stroke and intracranial hemorrhage. As you mentioned, Dr. Samer, it will take a long time and will increase ischemic time risk, and we lost the patient at that time.
Not only this reason. The reason why also because why going to help? You already have all the information. What the CAT scan give you more information you need.
No, you already did the angiography and you already know what is the issue now.
So CAT scan just wasting of time.
Yes.
So let's go to the next one.
Okay. C, continued systemic hibernization and transport to neurologic intensive care unit for resuscitation. You already there is already as mentioned in in the question, there is already thrombosis, so we will not solve the issue. So it will continue.
So we don't because it's acute, right?
Yes.
It's like any acute stroke, less than 4 hours, just happened now. It's the time for right, or TBA or catheter-directed thrombectomy. So it's not a time for conservative management. So this is wrong.
Yes. The immediate catheter-directed glycoprotein 2B3A inhibitor and recombinant tissue plasminogen activator. As you mentioned, to some, this is
Best answer.
the best answer. And E, deployment of second stent up to the level of the filter with balloon angioplasty.
No, yeah, because you don't know what's the issue now. So how are you going to go with a, we don't know what's the problem. It's a clot, it's dissection, so you can know. First you have to dissolve the clot, take it to an angiogram. If you find dissection, then you do a stent. But you can't go
Yes.
like with another stent, you know, then you have a clot and you squeeze it, go to the brain. So you don't do that, you know. The bad thing in this situation, as Dr. Omar said, first thing you call the neurointervention, you know. Get them on board because this is, you may have to do more, you know. But the teaching we had before that, first thing the time when you move the filter, everything will open up. The filter full of clot or thrombus, the moment you remove it, do angiogram, thing looks fine. But the most important, keep your wire. It's very important. Dr. Muhammad Rafat mentioned that we do a pre-op angiogram before any intervention. I do the same. You need to, you know what your baseline. Because if you don't do it and then after you finish your angiogram, you don't know what's new and acute and chronic, you know. So you have to do intracranial angiogram before sending stenting. I do that routinely. And I was happy to hear that Muhammad Rafat does the same because I thought people stop doing that. Because I saw some people in neurointerventions, they don't do that. They go right away to that stenting and angiogram. All right.
Dr. Samer, one question. In this question, we changed the scenario that revealed dissection in the internal carotid artery. So should we do another stenting as mentioned in the last an E, deployment second stent?
What's the question? Sorry.
The question, if it is the angiography is revealed dissection rather than acute thrombus in this question. So should we do another stenting and choose the E answer? Stent the
Yes.
second.
And also how far the dissections, right? All the way inside the brain sometimes, and how is it flow limiting? Well, not flow limiting. So it depends. You cannot just go blindly like that. But if they give you like question blindly, yes, I will stent. But real life, you have to assess situation. See if it's, because not every dissection, you may leave it alone if you see not flow limiting, you know, going inside the brain. If it's limited, not limited, where is it? So I think make a difference.
Yeah.
But in general,
Yes,
Omar, you want to
I have a
finish off?
comment
Go ahead.
about this question. This question, I think it's unfair to candidate. Number one, usually we do carotid stenting while the patient is under ACT of 225 to 250, which stops any ability of an artery to thrombose. This number one. Number two, angiography usually when you get a filled up filter will get you a stagnant column of blood, which you're not sure is it thrombosed or just a stagnant column. And when you pull the filter and you take the material inside it, usually flow comes on. So to see immediate ICA thrombosis, I haven't seen it in my life. And angiogram cannot give you diagnosis of an acute thrombosis. It will give you no flow in ICA, but it wouldn't mention if this blood is fluid or thrombosed. It wouldn't give you this information. You might have it by maybe sophisticated duplex, but not by the angio. Thirdly, we are in the Royal College when we put a question asking candidate, we must be very clear what is the management in this scenario. So here, I wouldn't agree that angiogram shows thrombosis. I would say it wouldn't. It will show no flow. Secondly, the appropriate step is to pull the filter, take it out, and repeat the angiogram. This is the logic step which is not found in all these options. So, number one, situation is vague. Number two, it's unusual in clinical practice. We all follow ACT, and actually I do ACT while carotid stenting every 30 minutes. Make sure that patient is fully anticoagulated. And this will paralyze any blood from being thrombosis. So it's not a question that I do like, but they have very good discussion. But this is my comment. If it was me, I wouldn't approve this question to go to the exam.
I agree with you, Muhammad. As I said, the reason why I said the first thing, you know, I didn't see putting the filter. Because, I mean, I never saw any thrombosis. As you said, I saw a couple cases we don't see flow. But the moment I pull the filter, you repeat the angiogram, everything looks beautiful.
Exactly.
So I don't think it's a good question. But again, the reason why I don't want guys to solve the question, we want to learn from this, subject. So I don't want just because some of the question, as Omar said, I don't agree with them or with not correct or not well written. But the whole idea is just to stimulate discussion and we learn from these cases. All right, let's go to the next one now because maybe 10 minutes more and we're done. It's been like more than 1 hour now. Number 7, who's going to go now? Abdullah, نرجع عليك Abdullah.
So an